طيب. All right. Bismillah. We're going to continue. We finish the lower limbs and we're going to continue from the head and neck. As I said, it's just the high yield points that you will face in your exam. That's what we're going to tackle. We'll start by the cranial nerve, okay? So for cranial nerve, I just want you to know that for MRCS Part A, cranial nerve are tested repeatedly in anatomy, clinical scenarios, trauma, neurosurgery, ENT, ophthalmology, and head and neck surgery. The best way from our side, we think you need to know the type of the nerve, the origin, the function, the course, the major branches, the clinical importance, and the surgical point about the nerves. Okay. So I'm not gonna like read everything written here. I will just focus on what you need for your exam to pass. Okay. So firstly, you need to know that we have 12 cranial nerves, and you need to know the type of the cranial nerve. Is it sensory or mute or motor? So we have pure sensory nerves or mixed. So you have sensory, motor, and mixed. Pure sensory nerves is cranial nerve 1, 2, and 8. Okay, olfactory, one optic, and then vestibulocochlear. The olfactory for smelling, obviously. The optic is for vision, and vestibulocochlear is for hearing and balance. And if you, it's very obvious, all of these are just sensory. There's no motor function. Okay. Pure motor nerves are three: oculomotor, cranial nerve 3, cranial nerve 4, trochlear, cranial nerve 6, abducent, accessory 11, and hypoglossal 12. And this is the mnemonic 3, 4, 6, 11, and 12. Mixed nerve is one. It shouldn't be one. It should be glossopharyngeal, facial, vagus, and trigeminal. Okay. So I'm just gonna take this mnemonic out because the mnemonic, this one won't help you to memorize them. So you have 7, facial, vagus, glossopharyngeal, which is 9 and 10. So if you want to use this one, think about it backward: 5, 7, 9, and then 10. Okay. Okay. All right. Brainstem origin of cranial nerve. Sometimes you may be asked what nerve coming from midbrain, what nerve coming from bonus, and what nerve coming from medulla. As you know, the midbrain, the bonus, and the medulla are the brainstem organs. From the midbrain, you have cranial nerve 3 and cranial nerve 4. For bonus, you have cranial nerve 5, 6, 7, and 8. For medulla, you have cranial nerve 9, 10, 11, and 12. Okay. And this image explains the origin of the cranial nerve. Okay. So all of this is the midbrain. All of this is the midbrain. Midbrain has three parts. No, brainstem. I mean, all of this. This is the brainstem. This is the brainstem, and the brainstem has three parts: midbrain, bonus, and medulla. Just memorize which part of the brainstem gives which part of the nerve, and this image will help you for that. Okay, you don't need to memorize the nucleus. No need to. Just which cranial nerve coming from which part of the midbrain. Now we're going to tackle each cranial nerve by itself, starting with the olfactory. This is the olfactory nerve. Here it's a cranial nerve 1. And look, this is the distribution of it. And we said it's just sensory. It has no motor. Pure sensory nerve. Function is smell, obviously. The course of the nerve coming from olfactory receptors, this will go to cribriform blade. All right, this cribriform blade. Then this will form the olfactory bulb, which will form the olfactory tract, which will go to the temporal lobe. If you ask me this high yield, no, I wouldn't say this high yield. I just want to make sure you understood it. Okay, just bear with me 1 second. All right. So the clinical correlation, we have what we call ankle tumor, which is a tumor on the specific side. This will lead to olfactory hallucination, involuntary chewing movement, and disturbed consciousness. This will usually be temporal lobe irritation involving the olfactory cortex. So on the temporal side, we have what we call the uncus. Let me show you the uncus here on an image. And as we said, the olfactory nerve reaches the uncus at the end on the temporal lobe. Okay? So the uncus is part of the temporal bone. The uncus is part of the temporal bone, is here. Do you see this image? We call this uncus. So this is the uncus, and it's part of the temporal bone. We said the olfactory nerve reaches the temporal bone, the temporal lobe, I mean, sorry, the temporal lobe around here. So if you have a tumor around the uncus, this may lead to olfactory hallucination, involuntary chewing movement, and disturbed consciousness.
The screen is not shared.
Oh, sorry, Mustafa. Thank you for picking that up. My mistake, sorry. Yeah, let me just repeat the point again I just mentioned. So this is the uncus here. And we said I'm giving you the clinical correlation of each clinical nerve, of each cranial nerve we're going to go through. If you have ankle tumor, which is from the uncus here, which is part of the temporal lobe, this may lead to olfactory hallucination, involuntary chewing movement, and disturbed consciousness. And why is that? We said on the course of the olfactory nerve, you will reach the temporal bone. The temporal lobe, I mean, the temporal lobe. So the olfactory cranial nerve starts from the olfactory receptor, goes to cribriform blade, then to olfactory bulb, and then olfactory tract, and then temporal lobe. Okay. If you have a lesion in any area of the course, this may lead to anosmia, which is loss of smell. This could be due to fracture of cribriform plate, head trauma, or meningioma. And that makes sense. If you affect the olfactory nerve, this what will lead to? You will lose the smell. All right. Second cranial nerve, the optic nerve, is pure sensory, as we said, function the vision. The visual pathway of the optic nerve starts from the retina to the optic nerve, then to optic chiasm around the pituitary gland, then optic tract, then lateral geniculate body, then we'll move to the optic radiation, then the visual cortex on the occipital part of the head. Visual pathway lesion, optic nerve lesion produce ipsilateral blindness. So there's so many lesions that could happen because the optic nerve pathway is very long, as you can see here. Okay, so if you have a lesion around any part, this may lead to specific presentation. If you have optic nerve lesion, this may lead to ipsilateral blindness. If you have optic chiasm lesion, this may lead to bitemporal hemianopia, which could be due to pituitary tumor, and the reason would be compression of crossing nasal fibers. So the most high yield point you will get from this lecture today is this point. If you have a lesion on the optic chiasm, this will lead to bitemporal hemianopia. Bitemporal, so think about your vision as two parts. You have temporal, which is close to the temporal bone, the outer side, and you have nasal, which is on the inner side. When we say bitemporal hemianopia, that means you're gonna lose the vision of the outer side. So you won't see from here outward. Okay? Bitemporal hemianopia. And I'm sure I put an image for it. Let me just, there is a nice image for the lesion. I will show you here. So bitemporal hemianopia mean you are not seeing on the, bi mean twice. Bi mean on the both side. Temporal is temporal. Hemianopia mean not being able to see, right? Bitemporal hemianopia. Do you see? There is a nice image. Yeah. So this is a normal vision for everyone here. When we have bitemporal hemianopia, you will not see this part and you will not see this part. Where is that image? Okay, so we can put this one. So this is the black, the dark side here means that you are not seeing on this side. Okay, if you think about it, this is a temporal side, this is a nasal side, this is the nasal side, this is a temporal side. So bitemporal hemianopia mean you are not seeing on this both side. Okay, I hope this is clear. Give me thumbs up if you think this is clear. So is bitemporal hemianopia clear? If you understand it, yes, press on the, so Inas and Adil, Shaima, Mustafa. So everyone understand bitemporal hemianopia. Very high yield. Very high yield. Very high yield. MRCS Part A, MRCS Part B, any exam. This is a question. Okay. All right. So that's a bitemporal hemianopia. And we said the most common cause is pituitary tumor lesion. And the reason is compression of crossing nasal fibers. Craniopharyngioma lead to compressions of lower chiasm, and this may lead to bitemporal lower quadrantopia. So bitemporal mean on both sides. Lower, we mean the lower side. Quadrantopia meaning, quadra mean like quarter. Quadra meaning quarter. Okay? ربع الحاجة يعني quarter. Antopia meaning loss of the vision. So you will lose the vision on the lower side, on the temporal side, on both sides, and it's going to be quarter. So bitemporal lower quadrantopia, that's explain everything for you. So the names tells you everything like bitemporal hemianopia. All right. So in this image here, contralateral superior quadranopia, contralateral inferior quadranopia. Do you see? So I'm going to take this image from here because you need it. This will explain all the lesions for you. So let's put it on the top here. Okay. So all what you need to do is look at this image, see where is the lesion and how the lesion will affect you. Okay. So we have central scotoma here. You will have loss of lesion here. You have mononuclear visual loss. This will be due to complete loss of optic nerve here. You have bitemporal hemianopia, which we just spoke about. This is the temporal side here and here. And you have contralateral homonomous hemianopia. By homonomous, we mean on contralateral side. Okay, homonomous, meaning so you have nasal on this. This is the temporal side. This is the nasal side. This is the temporal side. This is the nasal side. This is the temporal side. So you have temporal and nasal on this side. Contralateral superior quadrantopia, and then you have contralateral inferior quadrantopia. On this image, all of it is high yield for part A and part B. The most important high yield one is this one, bitemporal hemianopia. Each exam in MRCS Part A, part B, even the USMLE exam, this is the question around here. Okay? All right. Pituitary tumor, we spoke about that. Optic nerve lesion produces contralateral homonomous hemianopia. If you want to understand what does this mean, you come to the image and see it here. All right? Here, contralateral homonomous hemianopia. This one. Temporal optic radiation, we call it also Meyer's loop. This produces superior homonomous quadrantopia. Okay? So how can you memorize this one? Pi in the sky, meaning superior for B. Pi in the sky. This contralateral superior quadrantopia. This is the one. And this is the Meyer patch radiations. This is the one. So this image explain everything. Okay? Explain everything. All right. So surgical point,
how
right?
to use the mnemonic pie in the sky?
Pi in the sky meaning like you know the word pi. You take the P for superior, and then it looks like this. Pi in the sky. Like, do you see? It's half of it. Pi mean like a slice of
Okay.
cake. Okay, in the sky. Okay. Um, light, light reflex. It's a very long lecture, so I'm just gonna try to be as brief as I can. So the pathway of the light goes to the retina, then the optic nerve goes to the brainstem, oculomotor nerve. This will lead to pupil constriction. So the pupil constriction is due to the oculomotor nerve. Then the afferent limb goes to through cranial nerve 2, which is optic nerve, and the efferent limb. So afferent mean like afferent producing, sending. Efferent mean importing or accepting through the cranial nerve number 3, act on both sides. Why this is important? We're gonna speak about this in pathology more, because this any effect on this may lead to Marcus Gunn pupil. Okay, light directed into affected eye. This will lead to no direct response, no consensual response. Meaning, if you directed the light on this eye will not be affected, and the contralateral eye will not be affected also. Okay, usually when you direct a light here, even if this eye is not working, the contralateral eye will constrict. If you have no response on this side or no response on this side, this is Marcus Gunn pupil. If you directed the light into the normal eye, this will lead to both pupil constrict. And the lesion in this case is in the optic nerve. So how this will present to your exam, they will have a scenario. They will say light directed in affect in the right eye, no direct response. And on the right or the left, by meaning no response on the consensual response, meaning we directed the light on the right one. All right, no consensual response on the left also. And when we directed the light on the left, both pupil constricted. Okay, that will be a scenario. And then they will ask you where is the lesion. The lesion is in the optic nerve. Okay, there is multiple question about this in Fauzia notes. We'll come to it later on. I just want you to remember this phrase, Marcus Gunn pupil, because they may ask you about, they may give you the scenario and ask you what is this, or they may give you a scenario and ask you where is the lesion. So do you see here? Let me just maximize this image. Let me just put it in the center. All right, this eye in the dark, normal OD constrict fully to light. So the normal person, when you put a light here, is constrict. Okay, here you put a light around here. Do you see? There's no constrict, no constriction on both. But when you put a light on the normal eye, both of them constrict. Okay, this is a good image actually. This is the Marcus Gunn pupil. Give me thumb up if you understand the Marcus Gunn pupil.
If
Okay.
the normal response when we put the light in the normal eye, what should it be? Just one pupil considered?
No, the normal response for a normal person like you and me, when you put the light on the right or on the left, both eye constrict, Mustafa. That's why when we
So here
examine
there is
our
no.
sorry.
So here there is no lesion when you put light directed into normal eye. Both
Yeah, but
pupils
when you put
constrict.
it on in the abnormal eye, none of them constrict. Do you see that one?
This is the. But the fourth line is normal, right?
The fourth one is normal, but that means the left one is normal. This one is normal. However, this one is not normal because when we examine it here, think about it like this, Mustafa. Both of these is one exam, and both of these is one exam. Do you understand? So on this one,
Okay.
we examine the left, which is normal. Okay. We examine the
Okay.
right, which showed no constriction on both sides. However, when we examine the left became normal. That means the issue is around here on the right. Okay?
I didn't get it. I don't know. Can you
It's very,
repeat it,
yeah.
please?
Let me, are you okay? Listen, it's very simple. So there's two or three choices. You could have one eye normal and one eye not normal. Is that okay for you?
Okay.
So you may have one eye normal and one eye not normal, okay?
Okay.
So in this case, the abnormal eye is this one, Mustafa. I'm not sure is it right or left for you, but I'm doing a circle around it. This is the abnormal eye on this side. Is that
Okay.
clear? All right. So in here, there's no light. Both pupil are dilated. You put a light on the left side, is constrict on both sides. All of this is normal. Okay?
Okay.
Here, we said the problem is on this side, right? So let's start from down there. You put the light on the normal side here on the left. You see the arrow? Both pupils
Yes.
constrict. Okay? So here on the left side, everything is normal. However, when you put it on the right side here, there's no constriction on this side and there's no constriction on this side, which is abnormal. So the issue is around here, not here. Okay?
Okay. Now
Yeah.
it's clear.
Yes.
Thank
Okay.
you.
Let's continue. All right. Oculomotor. This is the third nerve. You can have a look at this image. So the oculomotor supplies most of the eye muscles. Okay? Supplies most of the eye muscles. As you can see here, this is the oculomotor. Cranial nerve 3 supplies the levator palpebrae superioris and superior oblique muscle and superior rectus. It's also supplied the inferior oblique, inferior rectus. The only nerve that's not supplied by the only muscle that's not supplied by the oculomotor is lateral rectus. Lateral rectus is supplied by abducens nerve. And how can you memorize this? Just write LR6. So lateral rectus supplied by the 6. The rest is supplied by oculo. The rest is supplied by oculomotor. Okay. Is that clear? Okay. The type of the nerve, the type of this oculomotor nerve, as we said, is pure motor with parasympathetic fiber. Origin from the midbrain here. It's coming from the midbrain. This image will give you a lot of information. So have a look at it later on. Okay. Supplies extraocular muscle, including superior rectus, inferior rectus, medial rectus, inferior oblique, and levator palpebrae superioris. Does not supply the superior oblique or the lateral rectus. So superior oblique or lateral rectus. Superior oblique supplied by cranial nerve 4. And lateral rectus supplied by cranial nerve 6. Okay, mnemonic. LR6 mean lateral rectus 6, which is abducent, superior oblique 4, and rest by the 3. Okay, so you just need to memorize this one to get all the muscles of the eye. All right, parasympathetic supply, we're still talking about the oculomotor nerve. Will give you sphincter pupillae ciliary muscle, responsible for pupil constriction and accommodation. Okay, clinical lesion of oculomotor nerve may lead to ptosis, dilated pupil, eye down and out, or diplopia. All right. So if you have a scenario in your MRCS exam and you have your patient, the scenario says the eyes are down and out, that's oculomotor nerve lesion. All right. If it's ptosis, that's also an oculomotor nerve lesion. Why? Because the oculomotor supply this muscle, levator palpebrae superioris. From the name, levator mean it does raise, right? Levator, elevate something. So levator, if the upper eye is not elevated, this may mean it's downward. That means it's ptosis. The word ptosis mean like the eye muscle is coming down like this. Okay. All right. Raise intracranial pressure. This is also another surgical point. Raise intracranial pressure may compress superficial parasympathetic fiber. This may lead to fixed dilated pupil. Reason is unopposed sympathetic activity. This may happen after head trauma. Horner syndrome, very high yield for your exam and for your life. Sympathetic lesion. So Horner syndrome usually will happen due to sympathetic lesion, due to tumor, Bankos tumor, or whatever, apical tumor of the lung metastasized to sympathetic lesion. There is a sympathetic lesion, meaning there is a lesion in the sympathetic chain. Horner syndrome, ptosis, meiosis, and anhydrosis. Ptosis, meiosis, and anhydrosis. Loss of superior tarsal muscle will lead to ptosis. Meiosis, loss of pupillary dilator, and anhydrosis, loss of sweating. Okay, there's also enophthalmos, aberrant sunken eye. This is not that important. Just remember
Dr.
ptosis.
Ali, the muscle is
Yes.
named superior tarsal
Where?
or,
Yes.
or superior rectus.
No,
Superior tarsal.
superior tarsal muscle. Yes.
Mm.
Not rectus. Not rectus. Ptosis, meiosis, and anhydrosis. Loss of sweating, early proximal lesion, late in intracranial late in intracranial lesions. So sympathetic lesion, let me just show you what the Horner syndromes look like. Just 1 second. Do you see? Ptosis, meaning the eyelid is coming down. Meiosis, do you see is constricted here, dilated on this side. And anhydrosis, the patient will not sweat on this side by anhydrosis. So ptosis, meiosis, and anhydrosis. This is another image. There will be ptosis, dropping of the eyelid, meiosis, constrict, and anhydrosis. So ptosis, meiosis, and anhydrosis. Okay. Let me just put it here. This is how to. All what I want you to remember: ptosis, meiosis, and anhydrosis. That's all what you need for your exam. Okay. All right. Cranial nerve number 4, trochlear nerve. This is a superior oblique. So this is a magnified image for the eye. This is a superior oblique. You have the trochlear nerve supplies the superior oblique here. It's a motor nerve, so there's no sensation. It's coming from the midbrain, supply the superior oblique muscle. Action. It thus causes depression, intorsion, and abduction of the eye. Unique feature is the only cranial nerve emerging dorsally, crossing completely before exiting. Longest intracranial nerve course. So if you've been asked a question in your exam, and the question is, you have a patient with intracranial pressure above than normal, what is the cranial nerve most likely to be affected? And this is a very high yield question on your exam. What's the most likely nerve to be affected by high intracranial pressure? What is the answer?
Cranial nerve number 4 trochlear.
Yeah, why?
لأنه أطول واحد longest.
Yes, can you say it in English?
Longest cranial nerve.
Okay. I have another question for you. If you answer this question, you have a prize. I'm going to give you a prize. I'm going to send you money. Okay? If you have a patient with diabetes mellitus, what is the most common nerve, earliest nerve to be affected?
cranial ولا peripheral?
No, cranial. I'm talking about cranial.
Optic.
Optic? No. No. Do you know, Mustafa? Mustafa, do you know?
Trochlear.
If anyone answer now, there's no prize, but why the screen is not shit? Okay, if no one is answered now, there's no prize for you, but give you a chance. This is also very high yield for MRCS Part A. Very, very high yield for MRCS Part A. Diabetes mellitus. What is the most common nerve to be affected? Cranial nerve to be affected. Oculomotor. Oculomotor. Cranial nerve number 3. Okay. All right. If you patient may complain of difficulty walking down stairs. So if you have a scenario and the patient is having difficulty walking down stairs, that's cranial nerve 4 lesion. Vertical diplopia or compensatory head tilt. So I just want you, I can't explain it to you, but it's very complicated. Your patient cannot look downstairs. So if you have a patient, if the patient is not able to move his eye down like this, so he's having difficulty walking down the stairs, that's likely to be cranial nerve 4 lesion. Okay, just memorize that, put it in your mind. You may have a question about that. All right, cranial nerve number 5, trigeminal nerve. I think it's the biggest cranial nerve, but let's see. Trigeminal nerve, it has branches: ophthalmic branch V1, maxillary branch V2, and mandibular branch V3. Each one has small branches. We have the lingual nerve, very important. We're going to speak about it later on. It's from mandibular branch here, from the trigeminal. Why is important? Because it comes around I think the salivary gland duct. So this lingual nerve, just memorize this one. Inferior alveolar nerve, not that high yield. Superior alveolar nerve, not that high yield. So the branches of the trigeminal nerve is ophthalmic, maxillary, and mandibular. Okay. It's a large. It's the largest. You want to say anything? Someone's mic is open. Fine. It's the largest cranial nerve. It's mixed, so it's motor and sensation. Origin from the ponus. Function Face sensation via V1 ophthalmic, V2 maxillary, and V3 mandibular. Exception, so it supply most of the head except the angle of the mandible from the great auricular nerve. This point is very high yield. Angle of the mandible is supplied by the great auricular nerve. Very important. All right. The motor part of the trigeminal, only V3 contains motor fibers, which supply muscle of mastications, including masseter, temporalis, medial trigoid, and lateral trigoid. Okay. I'm going to show you the image of this in a second. Additional, it will supply mylohyoid, anterior digastric, tensor palati, and tensor tympani. So this is the motor part of the trigeminal. V1 ophthalmic division is the smallest branch, is pure sensory. As we said, the only mixed one, motor one, is the V3, mandibular one. The smallest branch, pure sensory, run with cranial nerve 3, 4, and 6 in lateral wall of cavernous. It does exit through the superior orbital cavernous sinus. It does exit through the superior orbital fissure. So this is high yield because we're going to speak about the cavernous sinus later on, and you need to know which nerves coming through the cavernous sinus. Okay, it gives you, so the ophthalmic division will give you smaller branches: lacrimal, frontal, and nasociliary. Lacrimal, frontal, and nasociliary. Okay, so these are the branches of the ophthalmic division of the trigeminal. Okay, maxillary division, which is pure sensory, it goes from the middle cranial fossa to the foramen of rotundum. We're going to speak about the skull foramen in the next section. Goes to be through pterygopalatine fossa, then infraorbital foramen. It will give you smaller branches: pterygopalatine, infraorbital, zygomatemporal, and zygomatofacial. This you can memorize it by the word pizza. Pizza, yeah. So BIZ, and here is alveolar. You remember it by alveolar, A capital. Let's make this small so you understand. And let's make this double Z. Okay. Clinically, if you have head trauma and you have numbness in the cheek, this may mean that there's infraorbital injury. Mandibular division, which is V3, is the largest branch السلام عليكم.
عليكم السلام.
البتاع انتهى 200. النت وقف من 200. اخر نقطة حصلناها شنو؟ يا
في
صفوت.
التراجمينال في التراجمينال آخر حاجة.
ريلي
مم.
انا مشيت الابدوسنت ومشيت ديد كونتينيو. ما مشكلة. trigeminal fine. Let's go back. Really? From trigeminal.
أيوة من التراجمينال.
exactly in the trigeminal part. ما اعرف الحصل شنو. هل النت وقف ولا شنو؟
فجأة أنت طلعت من
محاضرة ولا انا براي؟ ايوه في مشكلة. يس يا صفوت. Okay, fine. So the last sentence I mentioned, does anyone remember? Like what part of the trigeminal exactly? Did we speak
الشير
about the mandibular divisions? كان نعمل لكم شير. طيب حصلنا هنا يا شباب في المرة اللي فاتت. افتحوا المايك اتكلموا معاي سمعوني. حصلنا دي. Did we reach this point? Okay. You know what I'm gonna do? I'm just gonna start from the trigeminal. If there's any issue and you can't hear me, Mustafa, please call me. I don't know what happened. I think my internet lost. I lost my internet, that's why. Just 1 second.
was not near my phone. Now it's okay, everything.
طيب تمام. Let's start again. Okay. Just put for in the group Mustafa and me, we are back. All right. So we're going to continue from the trigeminal nerve. As we said, it has 3 branches. It has 3 branches: ophthalmic branch, maxillary branch, and mandibular branch. Ophthalmic is V1, maxillary is V2, and mandibular is V3. All right. It's the largest cranial nerve. It's a mixed nerve, meaning sensory and motor, originated from the bonus. Sensation, it gives sensation to V1 ophthalmic, V2 maxillary, and V3 mandibular. Exception, angle of mandible, which is supplied. Yes, Mustafa.
Did you start the recording?
Yeah, video is recording. Yeah.
Okay, nice.
Yeah. Angular branch, angle of mandible was supplied by greater auricular nerve. This is very high yield. Angular branch supplied by greater auricular nerve. Okay. All right. Motor, only V3 contains motor fiber. That's why we said it's mixed. Supplies muscles of mastication, including masseter, temporalis, medial trigoid, and lateral trigoid. It also supplies mylohyoid, anterior digastric, tensor palati, and tensor tympani. This is more details about each one. V1, V2, and V3. All what I want you to know is that the ophthalmic division, V1, is the smallest branch. It runs in the lateral wall of cavernous sinus. This is very high yield because the cavernous sinus thrombosis will affect the ophthalmic division of the trigeminal nerve. We're going to come to this in a second. All right. The branches of the ophthalmic one are three: lacrimal, frontal, and nasociliary. Second division is maxillary division. Is pure sensory. It comes from the middle cranial fossa to the foramen rotundum. We're going to speak about the cranial fossa in the next lecture. Trigopalatine fossa and infraorbital foramen. The branches are in the word pizza: trigopalatine, infraorbital, zygomatocumbral, and zygomatofacial, and superior alveolar. So here the A is for alveolar and superior alveolar. Okay. All right. Clinically, if you have head trauma and your patient has numbness in the cheek, that means that there's infraorbital nerve injury. Okay. Mandibular division is the largest one, is mixed, and it does exit the foramen or veil. We're going to speak about the foramen in the next section. The branches in the word ALI are auriculotemporal, lingual, and inferior alveolar. The most important one is the lingual one. Why? Because it goes lateral below and then medial to submandibular duct. And when you do a surgery to the submandibular duct, you may injure the lingual nerve. I'm going to show you the duct in a second. It supplies the general sensation to the anterior two-thirds of the tongue. Clinically, if you have a third molar extraction, if the dentist took the third ocular out, they may injure this lingual nerve. Inferior alveolar nerve goes from the mandibular foramen to the mandibular canal to the mental foramen to the mental nerve. Supply the lower teeth, lower lip, and chin. Clinically, if you have a patient with head trauma and they told you in the scenario he's complaining of numbness of the lower limbs now, then think of injury. Think about this one, inferior alveolar nerve. So in the exam, in your MRCS exam, part A, you will have a patient who had head trauma presented with numbness on the lower lip. Then they will ask you which nerve injured. This is the inferior alveolar nerve. Okay. Now the longest cranial nerve, abducens cranial nerve. Abducens cranial nerve is the longest one. If you have increased intracranial pressure in the skull, skull, this may affect this nerve because it's the longest one. If you have a patient with diabetes mellitus, think the first nerve to be affected is the oculomotor, cranial nerve 3. Abducens is pure motor, originates from the ponus, supply the lateral rectus. It will lead to abduct of the eye, meaning moving the eyes outward. When you move your eye this way, outside, that's abduct. Okay. If you have a lesion, this may lead to failure of eye abduction, meaning the eye will come together like this. Okay. That's failure of abduction. Medial deviation and horizontal diplopia. Has longest intracranial course, may lead to very sensitive to raised intracranial pressure, as we said. Okay. False localizing sign, we're going to speak about it in the pathology, but false localizing sign means you have a lesion in an area, however, the symptoms appeared in a different normal anatomy for it. Okay. We'll speak about that in the pathology. Facial nerve, cranial nerve 7. It's a mixed nerve, meaning motor
Dr.
and
Ali,
sensory. Yes.
the
Yes, Mustafa.
trochlear nerve also is having long intracranial course, right? Trochlear.
No. The longest one is the abducens one, not the trochlear. Do you see, Mustafa?
You said if we have high injury or something like this.
No, if we have high intracranial pressure, the most nerve that could be affected is the abducens. If I say the trochlear, that means I'm wrong, or I said it by mistake.
What is the question that is related with the trochlear?
There's no question related with the trochlear. The question related with oculomotor. If you have a patient with diabetes mellitus, the first the nerve will be affected, the oculomotor one.
You said if we have high high injury, and Safwat answer this question. If we have high area injury or something like that.
No. That was the intracranial pressure. Intracranial pressure, and
Safwat, can you remember? Safwat, can you remember the question? Because you said it has long intracranial course also.
the longest intracranial course is abducens nerve, not the trochlear nerve, Mustafa.
Not the longest, but it has long also.
No.
The trochlear, right?
Look, there's two cranial. Look, even if we say the trochlear, that means we did something wrong. So you have two nerves: either abducens nerve in the increased intracranial pressure, or oculomotor nerve in diabetes mellitus. That's it.
Can you open the information about trochlear nerve, which is written in the material? I think this is the oculomotor. Yes, here. Go down, please. Yes, longest intracranial course.
No, okay. So let me just double check this one for me and you. Longest intracranial nerve. Oh, trochlear. Intracranial cord, cranial nerve, the vagus nerve. Okay, so V is troch is abducent. The longer the okay, the thong. Okay, so abducent is the second one. Fine. Okay, so that's mean I said longest intracranial course followed.
This is right. This is right.
Yeah, followed by abducent. I'm just gonna make abducent as the second one. Okay. All right. So the longest one is trochlear, and the second longest one is abducent. This will make both of them susceptible to increase intracranial pressure. I hope this is clear, Mustafa. That's even a new information, not a new information for me, but that's an update for me. Is it clear? So you have the longest one, trochlear. The second longest one is abducent. Both of them are likely to be affected by increased intracranial pressure. And if you have a patient, a patient with diabetes mellitus and they ask you which nerve is mostly likely to be affected first, is oculomotor nerve, which nerve 3. All right, facial nerve. Let's continue. It's a mixed nerve, meaning it's sensory and motor, coming from bone to medullary junction. It goes from the cerebellopontine angle to the internal auditory meatus. This is high yield, very important. Goes to facial canal and then exit through the stylomastoid foramen. Okay. So here is the internal acoustic meatus here, and this is a facial canal here. Obviously, this is a nerve here, comes out of the stylomastoid foramen. All right. Most commonly affected nerve in cerebellopontine angle is facial or vestibulocochlear. It also gives you parasympathetic branches, and it also gives you sensory branches. The zebra buggered my cat. We're going to come to that in a second. It does give you the greater petrosal, which supply the lacrimal gland and nasal gland. It also gives you the chorda tympani, supply the submandibular gland, sublingual gland, and taste anterior 2/3 of the tongue. It's affected by mastoid disease. It also gives motor supply to posterior belly, digastric, stylohyoid, stapedius, and platysma. So the platysma, which I'm going to show you of it, I'm going to show you an image for it in a second, is supplied by the facial nerve. Facial expression branches. So the facial nerve will end as a branch, either temporal, zygomatic, buccal, marginal mandibular, and cervical. How you can memorize this? The Zanzibar by Mota Ka, or the zebra buggered my cat. So you can memorize it by this. Okay. So Z for zygomatic. To Zanzibar by motor car, or the zebra buggered my cat. The for temporal. Z for zygomatic, Zanzibar. By buccal. Uh, motor for marginal mandibular. C for cervical. Okay, these are the branches. The zebra buggered my cat. Okay, I like to memorize the zebra buggered my cat. It's easier for me. All right. So this is all the branches of the facial nerve when it comes through here. So facial nerve is a very big nerve, has all of these supplies. Okay, lacrimal gland, nasal gland, submandibular gland, sublingual gland, test of the anterior 2/3 of the tongue, and then the zebra buggered my cat. So we'll come to this in the ENT, but when you have a stapedius lesion, your patient may have hyperacusis. Hyperacusis means the patient will hear more than a normal person. So if you have a scenario and your patient hears more than the normal person, that means your patient has stapedius lesion. Okay, stapedius is not working. All right, facial nerve lesion, upper limb lesion against lower motor nerve lesion. Okay, this image will show you the difference between the upper motor neuron lesion of the facial nerve and the lower motor neuron lesion of the facial nerve. What I want you to know, if you have a patient complaining of facial nerve lesion on both upper side and lower side, meaning he has ptosis, he cannot open his eyes, his mouth is deviated, he cannot smile, he cannot do this, that means upper and lower side, both of them affected. That means the lesion is on the lower side. Okay. If you have a patient with just lower side lesion, that means the lesion in the contralateral side of the opposite. So if it's just lower side, that means the lesion lower side of the left. That means the lesion is on the right upper side. Please tell me you understand the difference between the upper motor neuron lesion and lower motor neuron lesion. This is one of the most complicated concept, and it was headache for most of the students in medical school. I'm just trying you to put it for a memorization. If you have lower and upper side on both sides, that means the lesion on the same side of the lower side here. So upper and lower, the lesion will be upper and lower on this side. If you have just lower on this side, that means the lesion is put on the other side. And why is that? If you want to understand it, because the upper side is supplied by both sides, so it's contralateral. However, the lower side, each one is supplied by the cranial nerve. I'm going to show you this in a second when we come to the pathology, the facial nerve lesions. So here, side of weakness for the upper motor neuron lesion is contralateral, opposite of the lesion. Okay, here is ipsilateral, same side of the lesion. Part of face affected, lower face weakness only. Forehead is spared. Do you see? Forehead is spared. Upper and lower face weakness on forehead involved. This is for the lower motor neuron lesion. Okay. The reason for that, bilateral cortical innervation to the upper face, unilateral to the lower face. So there is bilateral cortical innervation to the upper face. Both sides are supplied. So if you have a lesion, if you have an issue on the upper side, that means it's cortical side. That means it's upper motor neuron lesion because it's in the cortical side, because you have bilateral cortical innervation of the upper face. However, there's unilateral supply to the lower side of the face. This sentence will make you understand why it presents the same way. Okay. Here you have common cause stroke, intracranial lesion, or brain tumor for the upper motor neuron lesion. Here you have parotid tumor, acoustic neuroma, base of the skull fracture, and Bell's palsy on this side. Okay. Clinical example, we said that stroke affecting corticopubular tract, causing contralateral lower facial weakness. Contralateral lower facial. If it's left lower side, that means the issue in the right cortical. Okay. Ask the patient to raise eyebrows. Just ask your patient to raise your eyebrows. In the upper motor neuron lesion, able to raise eyebrows, forehead, spared. In the lower motor neuron lesion, unable to raise eyebrows, forehead involved. Okay. Vestibulocochlear nerve is a pure sensory nerve. It's balance. Vestibulo for balance. Vestibular is balance. Cochlear for hearing. If you have a lesion on this nerve, this may lead to vertigo, hearing loss, tinnitus, and nystagmus. Temporal lobe lesion, auditory hallucination. We spoke about that earlier, if you remember. Glossopharyngeal nerve is a mixed nerve, origin from the medulla. This is a glossopharyngeal nerve here. Sensation, give general sensation and taste. Posterior third of the tongue sensation. Here, posterior third of the tongue sensation. Okay. Anterior two-thirds sensation, lingual nerve, that's the general sensation. Here's the taste. So you have the general sensation on this side, and you have the taste on this side. Taste and sensation, by taste meaning when you taste the food, sensation when you touch the tongue. So the tongue is unique. You taste and you also feel when you put your hand on your tongue. So it does has two sensations. The posterior third of the tongue, the taste and the sensation is by glossopharyngeal nerve. The anterior two-thirds, the sensation is by lingual nerve. However, the taste is by chordae tympani coming from the facial nerve. Okay, and we said the lingual nerve is important because of the anterior two-thirds sensation, general sensation, and it may be injured if you did submandibular gland surgery or third molar extraction. Parasympathetic nerve from the lesser petrosal to otic ganglion to parotid gland. All of this for the sensation of the glossopharyngeal. Motor, it does give supply to stylopharyngeus muscle. Okay, it does give a motor supply to stylopharyngeus muscle. It's not high yield, just know about it. So, and it also has a rule with the reflex, gag reflex. We don't do that anymore. Don't do any gag reflex on your patient to test this nerve. Okay, cranial nerve 10, vagus, major parasympathetic nerve, and is one of the largest nerve, one of the largest cranial nerve. I think it's the largest cranial nerve ever, going from here till your stomach, till your bladder area. It's a huge, huge, huge nerve, vagus nerve. And the word vagus, vagus mean ambiguous, not clear. It does supply everything, okay? Here, the distribution of the vagus nerve, as you can see, very long, look. All the esophagus coming down there. You have the recurrent laryngeal nerve here. Internal is divided into internal laryngeal and external laryngeal. Okay. Function: motor palate, motor pharynx, motor larynx, parasympathetic thorax, parasympathetic abdomen, and sensory fibers. It's also involved in the gag reflex, is the efferent limb, meaning when you do the gag reflex, the afferent, the one that take the sensation, is glossopharyngeal. The one that produce the gag reflex efferent is the vagus. Cranial nerve 11, accessory nerve, pure motor, originated from medulla and cervical cord, supply the superior scalenus muscle, sternocleidomastoid muscle, sorry, sternocleidomastoid muscle and trapezius muscle. Surface anatomy: crosses posterior triangle, junction of the upper third and lower two-thirds of superior sternocleidomastoid muscle, and junction of the upper two-thirds and lower third of the trapezius. Important, at risk during lymph node biopsy. This should have an image. I'm going to show you it in a second. Surface anatomy of the accessory nerve. You need an image for that. Surface anatomy of accessory nerve. Excuse me 1 second. Okay. So this is a sternocleidomastoid, and this is a trapezius. Okay. Why the accessory nerve? Cranial nerve, part of cranial nerve 11. Okay, here. So the importance of that one, if you are taking a biopsy, you may injure this nerve. Okay, accessory nerve. Okay, all right. Hypoglossal cranial nerve 12, pure motor, origins from the medulla, supplies all tongue muscle except palatoglossas. Palatoglossas supplied by the vagus, very high yield. I want you to memorize this one. So all the tongue muscle supplied by hypoglossas except palatoglossas supplied by vagus. I want you to memorize this one, okay? You don't need to memorize this image. However, you need to memorize this one. Palatoglossas supplied by vagus. This is very high yield. Okay, so palatoglossas here supplied by the vagus nerve. And here the function of it. Function is not important. Just memorize all of them: genoglossas, hypoglossas, styloglossas, intrinsic muscle, lingual branch of hypoglossal nerve. All of them supplied by hypoglossal nerve, except palatoglossas supplied by vagus nerve. Tongue protrude towards side of the lesion. If you have a hypoglossal nerve injury and the tongue moves to the right, that's mean the issue is on the right. And why is that? Because the normal gynoglossus overwork weak side and bully. Okay, so in your exam you may have a scenario. This is why this is important, why I wrote it here. You may have a scenario of a patient who had a tumor or whatever, and they tell you the tongue is moving to the left side. Okay, so the issue will be on the left side. So the tongue protrudes here, the tongue protrude toward the side of the lesion. They will ask you left hypoglossus or right hypoglossus affected. So you need to like memorize and understand this one. If you have a lesion in the hypoglossal nerve, the tongue will protrude toward the side of the lesion. So you need to memorize this one. Very long lecture. I even got tired, man. That's such a long lecture. I'm just gonna try. I'm gonna try my best to be a bit more quick. All right. For the foramen of the skull, I'm not gonna speak too much. This is the foramen of the skull, and this is the table we created for you to memorize it. What is the high yield of it? Okay. The high yield points of this table. Firstly, you have to memorize all this table. However, I want you to focus more on the points I'm gonna mention to you. You see this artery, middle meningeal artery. This is a very important artery. Why? Why do you think this is a very important artery? Middle meningeal artery. I want an answer. Everyone here, I want an answer. Why middle meningeal artery is very important?
This when you put the gun or something in the foramen, one of the foramen.
Yeah. No, what is the importance of the artery? Why is very crucial and why is very important? Middle meningeal artery.
Can't remember.
Do you remember subdural and epidural hematoma, Mustafa?
Yes.
So the middle
Subdural
meningeal
nerve.
artery, when you injure it, what do you like? What will you have? Epidural hematoma. Okay, it's very important because it's the artery that injured in the epidural hematoma. Okay, so this one, middle meningeal artery and vein goes through the foramen spinosum. Very high yield. I want you to memorize this one. Okay, you have to memorize this one. Internal acoustic meatus facial nerve. Very important. Okay. However, mentioning these two usually comes to your exam. However, I want you to memorize all of this, all this table. And this image will show you the foramen. Unfortunately, you have to memorize. There's no way around it. Unfortunately, okay? I'm not going to spend more time. All right. I think I don't want to make the lecture very long. However, let's tackle the cranial sinuses, pituitary gland, and Bitrion and CCF, okay? You can read everything here. However, this is the image I want you to memorize and have a look at. So the cranial venous sinuses are venous channel located between layers of dura mater. So they are between the dura mater. This is a high yield point. Here you have all of them, and you need to memorize this image, unfortunately. Okay. Here you have the name major cranial venous sinuses: superior sagittal sinus, inferior sagittal sinus, striate sinus, occipital sinus, confluence sinuses, transverse sinus, sigmoid sinus, cavernous sinus, superior petrosal sinus, inferior petrosal sinus. Important clinical point: because these veins have no valve, infection can spread easily. This is one of the important points I want you to memorize. There is no valve. It acts like a vein, however, there is no valves. Okay. Trauma over the vertex may injure the superior sagittal sinus, causing severe bleeding. Mastoid infection, this is the high yield one. Mastoid infection may spread superiorly to the sigmoid sinus and intracranial structure. So, any infection in the mastoid, you have to deal with it as emergency. Very important. All right. All right. Here you have the cavernous sinus. The cavernous sinus is a bad venous sinus located on each side of the sella torsica. This sinus is one of the most important because several cranial nerve and internal carotid artery pass through it or beside it. Content of lateral wall, superior to inferior. Oculomotor nerve, trochlear nerve, ophthalmic division, and maxillary division. If you remember, we mentioned that earlier. Structure inside the sinus, medial to lateral, internal carotid artery, and abducens nerve, which is cranial nerve number 6. Cavernous sinus here, very high yield. You need to memorize the structure, and you need to memorize which superior to inferior and medial to lateral. And here you have all of them. Okay, this is a cavernous sinus here, and this is a structure path through it. Very high yield, very important. Relation of cavernous sinus, medial to cavernous sinus, is pituitary gland here. As you can see, this is a pituitary gland. Around here, should be around here. Lateral to it, temporal lobe of the cortex. Here will be the temporal lobe, obviously. Cavernous sinus thrombosis. The face contains a dangerous area around the nose and upper limb. So we call this dangerous area around here. Let me just show you the image of it. Dangerous area. Do you see? This is a dangerous area of the face. We call this a dangerous area of the face, okay? Dangerous area of the facial vein are valveless, allowing infection to spread. So if you have infection around here, you have to be very careful with it. Okay, this may spread to the intracranial. That's why it's very important to be very careful if we have infection around here, okay? All right, facial vein, how will it spread? It will spread through the facial vein to superior ophthalmic vein to cavernous sinus. And usually on your exam, the vein that they want you to mention or they will put for you to answer is superior ophthalmic vein. Superior ophthalmic vein. They will say a patient had an infection around here or around his nose. What is the vein responsible for transmitting this infection to the brain? And the answer is superior ophthalmic vein. Okay. Therefore, facial infection can cause cavernous sinus thrombosis. All right. How the patient with cavernous sinus thrombosis will present to you: painful eye swelling, ptosis, ophthalmoplegia, meaning there will be paralysis around his eye. Okay. Cranial nerve paralysis, pulses, cranial nerve pulses, including cranial nerve 3, 4, V1, V2, which are branches of trigeminal, and V6. And it may allude also to gradual visual loss. Why cranial nerves is affected first? Because it lies inside the sinus. Oh, now I know why I mix it. Okay, all right. So the cranial nerve 6, which is abducent nerve, is the first one to be affected in the cranial nerve cavernous sinus thrombosis. Why? Because it's inside the sinus, close to the internal carotid artery. Okay. This information about cranial cavernous sinus thrombosis is very high yield, very important, especially this area and this vein, superior ophthalmic vein. Okay. Pituitary gland. This is a pituitary gland. Optic chiasm. You have hypothalamus here, and anterior pituitary and posterior pituitary. Here the sella torsica. Okay, sella torsica. All right. It's like the sella torsica of the sphenoid bone. They may ask you, sella torsica is part of which bone? Sphenoid bone. And is known as the master endocrine gland, obviously. Important anatomy. Superior related to the optic chiasm, connect the hypothalamus by the infundibulum. Anterior pituitary developed from the Rathke's pouch. Posterior pituitary developed from the neural tissue. Okay, this is important. Clinical importance. Pituitary tumor may compress the optic chiasm. This caused by temporal hemianopia. Yes, this is the image I was searching for. So the patient with bitemporal hemianopia, this how we'll see the wart like this. The wallet. This how we'll see the outside. It will be like this. Okay. I have a phobia now. I just want to make sure everyone is following fine. Don't okay. This so the patient with bitemporal hemianopia, this is how they will see the wart outside. Okay. Okay. Next important point is troin. Here, this area is very important. Why? Because it does contain a very important artery. We call it middle meningeal artery. All right, middle meningeal artery. Why is important? Because if it's injured, this may lead to epidural hematoma. An epidural hematoma can kill someone. So the troin or whatever, this one is the connection of frontal bone, parietal bone, sphenoid bone, and temporal bone. Here, all of them around here. For whatever reason, they like to ask question about this area. So troin is a connection of these four bones together. It's a weak area on the side of the skull where four bones meet. Do you see? So if you punch someone here, you may end breaking this one. And if you broke this one, you may damage the middle meningeal artery. Deep to troin, you have anterior branch of middle meningeal artery and auriculotemporal nerve. Both of them are important. Auriculotemporal nerve and middle meningeal artery. Clinical importance. Fracture of the troin can tear the middle meningeal artery, result in extradural or epidural hemorrhage, as we said. Typical presentation: head trauma, brief loss of consciousness, which we call it lucid interval, and rapid deterioration. Troin fracture, middle meningeal artery tear, extradural hematoma. Very important. Okay. Then cerebrospinal fluid. This cerebrospinal fluid, what does it do? Is protect and shock absorption, nutrient transport, waste removal, and maintain a stable environment. And this is the pathway from lateral ventricle to the foramen of Moro, third ventricle, aqueous of Sylvius, fourth ventricle, foramen of Loschka and Magendie, and subarachnoid space. This image explains the flow. Okay, have a look at it later on. Here, I'm just gonna mention the most important point for you. Let's say your exam is tomorrow and you have no time to study all of this. This is what I want you to study. The most common site of obstruction is aqueous of Sylvius. Obstruction causes dilated lateral ventricle, dilated third ventricle, and normal fourth ventricle. This results in non-communicating hydrocephalus. All right, your exam is tomorrow. You don't have any time to study. Cavernous sinus lateral wall, cranial nerve 3, 4, V1 and V2. Inside the sinus is internal carotid artery and cranial nerve number 6. Danger area of the face, may lead to cavernous sinus thrombosis, and I showed you the image of it here. This is the image of it. And the vein I want you to memorize, superior ophthalmic vein. And how you can memorize that one? The end of the triangle is around the eye. That's why it's superior ophthalmic vein. Superior ophthalmic vein, close to the eye. Okay. Dangerous area of the betroin, middle meningeal artery, extradural hematoma. Pituitary tumor may lead to optic chiasm compression by temporal hemianopia. Aqueous of the sylvus is a common site of cerebrospinal fluid obstruction. Very important. These last 3 or 4 points. All right. We're gonna finish with this one: ear, tongue, and nose, cleft lip, palate. However, I will give you break for 5 minutes. I need break myself too, and then we're gonna continue. Okay. We're gonna come back in 5 minutes if you want to drink some water. I will make sure the session will not finish more than 2 hours. So we will come back after 6 minutes, and then we're gonna continue for 20 minutes, and that's it. Okay. طيب يا شباب، السلام عليكم. بسم الله، نواصل. بسم الله. كنا وين؟ طيب, we will finish today with ear, tongue, tonsil, nose, cleft lip, and palate. We'll just be a bit more efficient. For each structure, we'll speak about the structure, relation, nerve supply, plus supply, lymphatics, and applied anatomy. For the ear consists of external ear, middle ear, and inner ear. This section focuses on structure commonly examined in the MRCS anatomy. I just want to emphasize this more. All right, for the external ear, we have auricle, pinna, we call it pinna, and auricle is composed of elastic cartilage covered by skin. Exception, ear lobule contain fibrofatty tissue. Here, no cartilage. This fibrofatty tissue, no cartilage. This is the structure of the ear. Have a look at it. Nerve, sensory nerve supply of auricle. The auricle is received overlying innervation from multiple nerve. Auriculotemporal nerve, which originated from the mandibular division of trigeminal nerve, as we said before, supplied the majority of the anterior auricle. And then the great auricular nerve, which originates from the cervical plexus C2 to C3, and this supplies the lower auricle and lobule. Lesser occipital nerve, which originates from the cervical plexus, supplies the upper posterior auricle. Auricular branch of vagus supply external auditory meatus and small part of auricle. All right. Because several cranial nerves contribute to ear sensation, pain from nearby structure may be referred to ear. If you have tonsillitis, tongue carcinoma, or pharyngeal disease, all of this could lead to pain around the ear. Sorry. Do you hear me, guys? My voice is clear, right? Is my voice clear? Yeah. Safwat, can you put a message in the group saying we started again, just in case if someone is not. Just put a message in the Telegram group saying we started again. Okay. Tympanic membrane separate the external ear and the middle ear. Okay. This is the tympanic membrane. This is the external ear. Anything before that is the external ear. Anything after that, middle ear and then internal ear. Okay. Separate the external ear from the middle ear. You don't need to memorize everything here. Just this is a tympanic membrane separating the external ear and the middle ear. Okay. Semicircular canal, auditory ossicles, elastic cartilage. Okay, there's a cartilage around here. This is the anatomy of the ear. Okay, so diameter of the tympanic membrane approximately 1 centimeter, oblique placed, concave laterally. Surface covering, stratified squamous epithelium. Inner surface mucous membrane, middle layer is fibrous layer. Part of tympanic membrane, two parts. Pars tensa is a large portion, consists of fibrous layer. Pars flaccida, small superior part, relatively lax. Relation, chordae tympanae passes medial to the pars flaccida. You don't need to memorize this one or this one, just know it. And just know that the chorda tympani, which is branch or division of the facial nerve, passes medial to pars flaccida. Middle ear nerve supply. Middle ear cavity receives sensory supply from glossopharyngeal nerve via the tympanic branch, forms the tympanic plexus, supply the middle ear mucosa, eustachian tube, and mastoid ear cells. All right. Because tonsil and middle ear shared cranial nerve 9 innervation, tonsillitis may cause referred ear pain. Ear pain may occur after tonsillectomy. Okay. So if you ask a question for a patient who had tonsillectomy or has tonsillitis and he is complaining of ear pain, then why that? That's because the cranial nerve 9 supply the tonsil and supply the ear. Okay. Facial nerve branches related to the ear. Two branches are anatomically important. Chordae tympani, course, traverse middle ear cavity, passes medial to tympanic membrane, exit skulls, this tympanotympanic fissure. Carries taste fiber anterior to the two-thirds of the tongue and parasympathetic fiber. More importantly, we said for the facial nerve, internal acoustic meatus. This is the important one. This is for the facial nerve. For the chordae tympani is the pitulotympanic fissure. Okay. Nerve to stapedius. Nerve of stapedius is also a branch of the facial nerve. We're speaking about the nerve, the branches of the facial nerve related to ear. This title I hope is clear. Okay. Supply stapedius muscle. Function reduce stapes movement. Damage may cause hyperacusis. Hyperacusis mean ability to hear far voices, or the normal voice for you, for the patient who has hyperacusis, will be magnified, will be higher volume, higher voice. Lymphatic drainage of the ear. Upper half drain to superficial parotid nodes. Lower half include lobule, drain to superficial cervical nodes. Okay, this is the ear. We finished the tongue. Tongue anatomy is frequently examined because muscle, nerve, and lymphatic pattern differ by the region. All right. So this is the anatomy of the tongue, not high yield. You don't need to memorize all of this. You need to memorize the sensation and the taste of the anterior two-thirds and posterior two-thirds, as we mentioned earlier. Muscles of the tongue divide into intrinsic and extrinsic. Intrinsic muscle remain entirely within the tongue substance. Function, change tongue shape. This is the intrinsic muscle. Action, curling, flattening, narrowing, and elongating. You know, when you move your tongue, you just do one of these: narrowing, elongating, flattening, or curling. Curling, when curly hair, when you shrink it. Extrinsic muscle originated outside the tongue and insert into the tongue. And they are styloglossus, hypoglossus, uniglossus, and palatoglossus. All right, these are the muscles of the tongue. With the image. All right, gonna speak about each one quickly. Not very high yield, just the most high yield part is what nerve supply them. Okay. Styloglossus originate from a styloid process inserted into the side of the tongue. Action, retract the tongue and elevate the tongue. Hypoglossus originates from the hyoid bone inserted into the side of the tongue. Action, depresses the tongue. Genioglossus originates from the superior mental spine of mandible. Insertion insert all over around the tongue. Action, it protrude the tongue. Anatomical significance, prevent tongue from falling posteriorly. Palatoglossus originates from palatine aponeurosis. Insertion in the tongue. Action, elevate posteriorly. Nerve supply of the tongue. Sensory supply differ by embryological origin. Anterior two-thirds, the general sensation is bilingual nerve, which originated from the V3. All right? This is the anterior two-thirds. For the taste, for the anterior set, from chordae tympani, which originates from the facial nerve. And I showed you the image of this before. So the tongue has two sensations: taste sensation and general sensation. The taste sensation of the anterior two-thirds is facial nerve through chordae tympani. So chordae tympani, branch of the facial nerve. The general sensation of the anterior two-thirds is lingual nerve coming from V3. And by V3 is the mandibular branch of the trigeminal, as we said earlier. Posterior one-third, the general sensation and the taste is glossopharyngeal nerve. This is the posterior two-third. Okay? General sensation and taste is glossopharyngeal nerve. Okay? All right. Motor supply supplies all the muscle hypoglossal nerve except palatoglossal supplied by the vagus. I keep repeat this information for you. I mentioned it in the previous section and I did mention it here too because it's very common, very high yield. All the muscles of the tongue supplied by hypoglossal nerve except palatoglossal supplied by vagus. How you can memorize this one? I'm just thinking of it. How you can memorize this one? Palatoglossal, think of it like barato, barao, barao. uh, palatoglossal barao. Yeah, palatoglossal barao. There's no other way. I don't think there's another way to like memorize this anatomy. So this is the image that I just mentioned. So here you have anterior two-thirds of the tongue. The sensory is
PV,
sorry, Mustafa or Safwan.
PV per vaginal examination.
Like okay,
PV.
this. But how can you memorize this one with the like? There's no connection. You cannot connect it unless you say barato and then barato. Palato
Your
glossus
one is
mean
nice.
yeah,
Parao.
yes. Okay. Anterior two-third sensory from lingual branch of V3 from trigeminal and test chordatum bni branch of the facial nerve. Posterior two-third sensory and test from the glossopharyngeal. So this image will make it clear for you. Hypoglossal, all the muscles except palatoglossal. Okay, which is a pharyngeal branch of vagus. Palato mean barao, vagus. Okay. Yeah, okay, yeah, I understand you now, Mustafa. BV by palatoglossal mean P palatoglossal and V vagus. Okay, that's could work. That's also could work. Yeah, vagus. Yeah, now it makes sense. Lymphatic drainage of tongue. Tongue lymphatic cross midline extensively. All right. The tip drain to submental nodes to the deep cervical node. Lateral anterior two-third drain to submandibular node to the deep cervical node. Central tongue and posterior third drain to bilateral deep cervical node. Unfortunately, you have to memorize this one. Tonsil. The palatine tonsil lie in the tonsillar fossa between the palatoglossal arch and palatopharyngeal arch. Here. Palatine tonsils, pharyngeal tonsils here, and lingual tonsils here. So you have three, and you have tubular tonsils too. 1, 2, 3, 4 type of tonsils. Okay. Here you have the palatoglossal arch we just mentioned. That's the palatoglossal arch, and that's the palatopharyngeal arch. Between them, you have the palatine tonsil. Do you see? This is the palatine tonsil, the palatopharyngeal arch, this is palatoglossal arch, and this is the uvula. Okay. Relation, lateral relation, superior constrictor muscle, deep to glossopharyngeal nerve, facial artery, and external palatine vein, not high yield. Arterial supply, main tonsillar branch of facial artery. So all what I want you to know, there's a tonsillar blood supply coming from the facial artery, mainly. Additional contribution, ascending palatine artery, ascending pharyngeal artery, dorsal lingual branch, and greater palatine artery. Not high yield, just remember, tonsillar branch coming from the facial artery. Venous drainage, external palatine vein to the facial vein. Lymphatic drainage, jugulo-digastric node, up a deep cervical chain. Okay. Here you have the tongue, lymphatic drainage, root to the deep cervical nodes, body to the deep cervical nodes, apex to submental node, lateral to submandibular nodes. Okay. Nose, external nose nerve supply from anterior ethmoidal nerve, plus supply of nasal septum. This is a high yield area. Rich vascular anastomosis occurs at little area. Very important. Why? Because if you have epistaxis on the anterior side, this is the area for it. Okay, this is the area for it. We call this little area. All right. I want you to remember that the epistaxis on the anterior side coming from the little area. And the branches of little area are these: septal facial branch, sphenopalatine artery, greater palatine artery, and ethmoidal artery. And if you want to know the full course of it, you have the internal carotid artery, will give a ophthalmic artery, which will give anterior ethmoidal artery and posterior ethmoidal artery. Okay? Here, you have the external carotid artery, will give the maxillary artery, which will give a greater palatine artery as a branch, and will give a facial. The external carotid artery also will give facial artery, will give superior labial artery and septal branch. Here will give maxillary artery, will give branches of sphenopalatine artery. Okay, all of this image, all of these arteries will come and connect around here. So this was supposed to come around here, and this was supposed to also join here, and this will give you the little area. Okay. Upper nasal cavity supplied by anterior ethmoidal artery and posterior ethmoidal artery, origin of the ophthalmic artery. Lower nasal cavity supplied by sphenopalatine artery and greater palatine artery, origin of maxillary artery. And this is the area of epistaxis. Okay. Cleft lip and cleft palate. Cleft lip occur due to failure of fusion between medial nasal process and maxillary process. I want you to memorize this one. They will present a patient who for you has a cleft lip, and they will ask you what is the failure. The failure of fusion between medial nasal process and maxillary process. They will mention a lot of stuff for you. However, the right answer will be failure of fusion between the medial nasal process and maxillary process. Okay. This image. Okay. Cleft palate, the failure due to failure of fusion between the right palatine shelf, left palatine shelf, and frontonasal structure. So I want you to memorize these three lines. What is cleft lip due to, and what is cleft lip, and what is cleft palate. Cleft lip, medial nasal process and maxillary process, failure of fusion, and cleft palate, right palatine shelf and left palatine shelf and frontonasal structure, failure of fusion too. I'm not gonna give you more than this. This is more than enough for today. Let me just make sure that's will we be able to finish. So for the next session, we have suprahyoid. I think we need to split into 3 sections, not just 2 sections. Okay, this is the sessions for today. Yeah, we need to split it into 3 sections. This was a long lecture. Any question? Any question? عندكم أي سؤال يا شباب؟
Can you repeat the upper motor neuron and lower motor neuron
Of the facial nerve؟
بطريقة مبسطة كده.
اوكي تمام. انا اشرح لك بالعربي كمان. اوكي. الفيشل نيرف يا مصطفى عنده supply from the cortical area. تمام؟ The cortical area. ايوه from the brain يعني.
تمام.
The cortical will cross, so the left will supply the right and the right will supply the left.
تمام.
معاي؟ طيب لو عندك cranial nerve injury في الابا موتر نيرون، باي ابا موتر نيرون معناه المشكله فوق، معناها عندك مشكله في الكورتكس، ستروك ولا تيومر ولا اي حاجه. تمام؟ لو المشكله في الرايت، لانه الرايت حاصل له سبلاي من الليفت برضه، يعني الرايت عنده سبلاي من الرايت ومن الليفت. لو حصل مشكله في الرايت هيحصل لك مشكله في اللور سايد اوف ذا فيس، لكن الابر سايد ما حصل لك فيه مشكله. ليه؟ لانه الليفت هيشتغل ويدعم لك الرايت، unless يكون عندك مشكله في الكورتكس من الجهتين الاثنين. لكن لو عندك مشكله في الجهه الرايت، الليفت بيجي بعزز. معاي ولا ما معاي؟
كده خليني اشرح لك انا فهمت شنو. طيب
طيب
آه البرين بدي سبلاي يعني
للفيشن نير.
كونترالاترال.
يس كونترالاترال، ايوه. طيب
لو في مشكلة في الرايت ارتري هيحصل
مره رايت ارتري،
ليفت.
رايت اريا، رايت فيشن نيوكليوس اريا. اوكي ايوه معاك.
يس،
اها.
في الرايت فيشيال اريا، في الرايت
طيب
فيشيال نيوكليوس هيكون في، يلا هنا هيكون في ليجن في اللور بس ولا في الابر واللور
حيكون الليجن
كونترالاترال؟
في اللور بس. ليه؟
اوكي.
لانه الابر مغذى برضه بالليفت. ما المشكله في الرايت؟
آه.
الليفت برضه بغذي لك الابر، فبالتالي الليفت حيقوم يشيل الوظائف بتاعت شنو؟ بتاعت الليفت اللي اتضرب اصلا. معاي؟ الليفت حيشيل لك الوظائف
الرايت،
بتاعت الرايت اللي اتضرب اصلا.
لو عندنا
فبالتالي
ليجن في الرايت،
لو
لو عندنا
عندك
ليجن
ليجن،
في الرايت.
لو عندك ليجن في الرايت حيكون عندك مشكله في اللور سايد اوف ذا ليفت، لكن الفوق ما بيحصل له حاجه. ليه؟ لانه الجزء الفوق الليفت حيجي يعزز له. فهمت الفكره ولا ما
يعني
فهمت؟
الليفت سايد مغذى ب بكم بكم
الليفت سايد
هناك.
مغذى بالليفت ذاته ومغذى بالرايت،
آه.
والرايت مغذى بالرايت ذاته ومغذى من الليفت. فهمت؟
طيب اذا 200 بيكون في ليجن في الابر اريا.
لما طيب عندك الرايت سايد اتضرب، تمام؟
ايوه.
الرايت سايد ليتس سي الرايت سايد كورتيكال هنا حصل له ليجن،
ستروك.
ستروك ولا وات ايفر.
تمام.
تمام؟ بيجي الليفت بيعزز له، فبالتالي ما حيكون عندك ليجن في الابا. تمام؟ طيب
اكزاكتلي.
سألت سؤال مهم. 200 بيكون عندك في الابا واللوا؟ بيكون عندك في الابا واللوا يا مصطفى لما تحصل لك ليجن في اللوا سايد اوف ذا نيوكليوس، في اللوا سايد اوف ذا فيشن نيرف. عندك الفيشن نيرف بعد ما جمع الاكشنات بتاعته كلها وجا ماشي، تمام؟ حصل لك كومبليت كات للفيشن نيرف، نفترض الباروتيد جلاند حصل لك انجري فيه، باروتيد تيومر اور وات ايفر، اور باروتيدومي. الفيشن نيرف الجاي من الرايت ده شايل حق الليفت للابر وشايل حق اللور بتاع الرايت، جا ماشي وحصل له قطعه. في حاله زي دي حيحصل لك باراليسيس للابر سايد واللور سايد. يعني الابر سايد ده يا مصطفى ما بيحصل له ليجن الا في حاله واحده بس، في حاله يكون عندك لوا موتور نيرون ليجن. في الابر سايد موتور نيرون ليجن ما بيحصل لك مشكله في الابر.
لا لا، واضح واضح.
تمام. الموضوع
تمام.
كومبليكيت
تسلم.
طبعا، ما بتتفهم بسهوله، ما انت عاين للصوره وتشوفها وتعيدها كم مره لنفسك، ما يعني ما كده طوالي كده حتقع عليك. انا
صح
عانيت
صح.
معاناه شديده مع ايوه في ايام السي ان اس. طيب يا شباب، في اي سؤال تاني؟ طبعا احنا والله مجتهدين شديد يا جماعه انه حاجه في الامتحان ما نخدها عليكم، ومجتهدين شديد انه نحاول نبسط المعلومات، لكن انفورشنتلي ده اناتومي. يعني لما نجي ان شاء الله للفسيولوجي والباثولوجي حترتاحوا حبه، لانه حيكون في فهم كثير ان شاء الله. يلا يا شباب، نتلاقى ان شاء الله المره الجايه. السيشن الجاي حيكون، خلوني بس اشوف 200. شكلنا حندخل سيشن ثالث لانه ده ما حيكفي. هيد اند نيك هنا، دي برضه حتكون هيد اند نيك. نحن الاناتومي بوليت دي كنا دار نشرح فيها شيت فوزيه وشيت اميمه، لكن غالبا دي حنشتغلها نظر سيشن، فانا حعدل في الجدول ده حبه ان شاء الله. تمام. يلا يا جماعه نتلاقى ان شاء الله، السلام عليكم.